Hi again, we're here with Dr Ralph Poppenbeek, occupational physician. And on this occasion, I wanted to have a chat to you, Ralph, about secondary psychological injury and talk to you about, what are some of the triggers in your experience that bring about secondary psych injuries, and particularly knowing that it makes up about 40% of all claims. Psych is such a prevalent incident that it bears comment around what are some of the things that contribute to the development of secondary psych issues, and what's some recommendations that you could provide, say, to a case manager or to a lawyer, or just from a practitioner perspective in general, that can help to mitigate the development of this, given it's such a significant and serious issue?
Yeah, I think in terms of physical injuries, a secondary psych issue is nearly always associated with inadequate or incorrect treatment or ineffective treatment. For instance, if a person's got a significant problem, the treating doctor or physio or whoever they go to delays referral to a specialist, that delays any surgical intervention. And people worry, of course. They're wondering about what's going wrong, what's the diagnosis, how serious is this, and it's stressful. The other thing is the workers' compensation system itself is stressful to deal with. I liken it to the old American term, the circus comes to town. It's a whole lot of people get involved. People who nobody pays much attention to, suddenly everybody wants to know them and want to have a piece of them. So it's understandable that the secondary psych issue will occur. I think this is the basis of a lot of chronic pain, where people get demoralized, they become very dependent on the system, they're trapped, and that creates stress, it creates anxiety, depression, in a vulnerable sort of person to begin with. And then that creates a further difficulty because anxiety causes muscles to tighten, that results in an accentuated pain response. And unfortunately, such an accentuated pain response is often treated by opiate analgesics, which is completely the wrong thing to use, in my opinion, rather than empowering the person to get out of the system and look after themselves and have psychological intervention if it's appropriate. So secondary psych issues, I think, are a real problem. I see them as quite common in the patients that I see for medical assessments. And they can be quite severe, but they're often poorly treated from my experience, and they often result from incomplete or unsuccessful medical treatment of their physical injury.
Yeah. So obviously a case manager is pivotal to the management of an individual who's put in a claim. And, you've mentioned that there's so many people, once somebody gets injured, there's so many people who are now party to the case or to the individual. The case manager being so pivotal and so important has got, I guess, a lot of influence and can have a really important role here in terms of how they manage, how they relate, how they communicate with the injured individual in terms of trying to minimise or mitigate the risk of the secondary psych. I know there's been a lot of work being done over in the UK around case management strategies and techniques to try and support resilience in the injured worker, and that often involves techniques around, who are the support people around the injured individual, but also as a case manager and the communication, the rapport, the level of interaction that a case manager has. What could you recommend as, I guess, some words of advice for a case manager in terms of, what they could potentially do to minimise the risk of secondary psych issues developing in an injured person?
Yeah, the obvious answer to that is to have an IME or medical assessment done early in the piece before the complications occur. Often that's done really early in terms of getting a liability assessment, but in the process of the liability assessment, I think it'd be useful to also ask questions about what would be optimal medical management to prevent complications from the particular thing. That's not often asked from my experience of liability assessment. So that's an opportunity that could be taken. The other thing is to choose the appropriate IME. Now, I'm not pushing any barrows here, but it's up to the referrer to choose who's the appropriate IME to refer the person to, and consider an assessment from a clinical psychologist who's got a reputation for making objective assessments. I'm also the medical consultant to Recover Rehabilitation in Melbourne, and we find this issue when we're grappling with how to deal with people in this situation. The feedback I get is that insurers are not terribly keen to do psych assessments for fear of creating a psych claim. But I'm talking about an assessment from a clinical psychologist rather than a psychiatrist. The problem with psychiatry assessments, if I can put in my little word here, is nearly everyone is diagnosed with an adjustment disorder with mixed anxiety and depressive mood. Now, I don't really know what that is. People I've talked to, the best answer I got from that was to call an adjustment disorder a prototype for a psychiatric disease. And I think that's probably a good way of doing it because it's evolving. But those kinds of things don't really help from a clinician's point of view. I think the payment of rehabilitation services could also be directed towards ones which empower the patient rather than make them dependent. Doing investigations, nerve blocks, all that kind of stuff. There can be medical benefit in all of those things. But from somebody who's anxious about having an injury or illness, anxious and depressed about not getting better, it would be useful to have them organized into a multidisciplinary rehabilitation program. This is what I often recommend in my reports, where they're seen by a psychologist, a physiotherapist, an occupational therapist, a personal trainer, or that's an exercise physiologist, that type of thing. And that's often coordinated by a rehabilitation specialist or an occupational physician, somebody like that. I think those kinds of things work well in defusing this sort of situation. And if the insurer can direct the rehabilitation process along those lines, I think that would be very productive. And from my experience, most GPs involved in these sort of things are pretty open to listening to advice from insurers as to what they would prefer done, because after all, they're paying the money in the end. So I think those are the two basic things of getting an assessment early in the piece, which is difficult for the case manager because they often don't have much face-to-face contact with the person. But getting an assessment done, if they're concerned along these lines, by somebody who understands the protocols, and trying to shift the rehabilitation process from traditional pain management in a purely medical sense to a more generalized multidisciplinary rehabilitation program. The only exception to that is people who do have psychiatric illness, and for that a psychiatric assessment is needed. But that's pretty rare, I think, in this circumstance.
And you mentioned that, early intervention is so important to try and mitigate the risk of secondary psych developing. And you also mentioned that it's very difficult for a case manager, and often case managers are dealing with over 100 cases at any one time. What kinds of signs would they look for? What would alert them to a potential secondary psych claim starting to develop? What would be some of the triggers, and therefore what would be some of the recommendations if a case manager was to start to notice triggers? What advice would you give them?
Oh yeah, that's a good question. The most obvious one is an extended period of time off work and excessively restricted work duties. Most people have an idea of what can be done and what can't be done. And if you find that that doesn't correlate, there's no consistency between the nature of the injury with the diagnosis that's been put forward and the nature of the restrictions, I think there's concern, that should raise concern. The other thing is things like frequency of visits to the doctor, the physiotherapist, the hydrotherapy, all that sort of stuff. If that frequency is high, then I think we've got to question whether the person's becoming dependent on the treater, and that's indicative of a secondary psychological issue. I think also the feedback you get from the claimant, some of them can be pretty vocal, and some of them don't say anything at all. Another thing too would be to get a treating doctor report from the treating GP or physiotherapist and find out what they think, how well they feel the treatment program is going. Of course, a pretty brave doctor who'll say my treatment program isn't going well. So there's a bias there. But you've got to kind of analyze these things. Most insurers have a medical advisor, and I think that's a useful reference point. But those are things I'd be thinking about. Also maybe feedback from the employer. Some employers are genuinely concerned about their workers and they might express that to the insurer. So it may be worthwhile to call the employer and say, how do you think this is going?
Yeah. Okay. Some great ideas there. Great, great insight into, you know, what are some red flag areas. Thank you for that. Last question then. You know, let's imagine that I did notice a handful of red flag issues as a case manager, and I had serious concerns that there were some other secondary issues developing. What kinds of things would you recommend as my next course of action?
Okay. I think a useful one is to involve an occupational rehabilitation provider and arrange for a case conference with the treating doctor and physio and people like that, and also a worksite visit, and then get some feedback from the rehab provider as to whether your concerns are justified. Again, an IME could be useful in that situation, depending on the circumstances. Getting a report from the treating doctor and the treating physiotherapist, and I think you can combine all of those three and get a fairly good idea of what's actually happening. But I think the rehab provider is probably going to be the most useful in this circumstance, because that's kind of your eyes and ears in the workplace and in the medical situation. And you can get a lot of feedback from that kind of thing. At Recover, we're often doing that sort of feedback to insurers and so on.
Yeah. Okay. Great advice there. Thanks, Ralph.
Fine, pleasure.